The title of the study is Hepatitis C, Barriers to Care in 2016. And the study was conducted at NYU Lutheran, which is a community hospital in Brooklyn, New York. And we wanted to ask the question of what is the rate of hepatitis C in our patient cohort. We have a very large diversity of patients coming from all ethnic backgrounds, and we were looking to answer that question. While doing the study, we started to ask a different question, which was, what are some of the barriers to screening these patients? We went over about 2,500 patient records for patients admitted from January 2014 to March 2015. And what we found was that about 75% of those patients who qualified for hepatitis C screening, meaning they were born between the years of 1945 and 1965, baby boomers, about 75% of them were left unscreened during their inpatient admission. So what we found was the reasoning for this. A large majority of them went unscreened due to issues with the electronic health record, as well as resident physicians circumventing these screenings for various reasons. So the unusual suspects, we focused largely on the physician barriers. So normally there are barriers to care at every level. There are patient-related barriers, there's access to care based on insurance, etc. There are cultural barriers, but this barrier we largely focused on was the physician barrier. Patients who were admitted to an internal medicine department in our 75 resident physician program were qualified for screening while they were in the hospital, but because of the electronic health record and the physician barriers, we left some of those patients unscreened. So the primary results of the study were that out of the 2,500, around that number of patients who were admitted, we had about 600 of them who were actually screened for hepatitis C. Of those patients who were screened appropriately, about 5% of them were hepatitis C positive, which is a higher seroprevalence than the national average, which is about 1.6 to 1.8%. Of the patients who were not screened, about 75% of them were not screened. The largest barrier was the physician barrier related to the electronic health record. So we have a few take-home messages. One is that screening patients is paramount because now we have curative therapy for hepatitis C. And these patients give us a good opportunity to screen in an inpatient setting because they are from a lower socioeconomic background and may not have access to care as an outpatient. So when they're inpatient, we have a unique opportunity to screen them. But there are still barriers to screening, and we can improve on that by improving our electronic health record, creating hard stops throughout the inpatient admission, from the emergency room to the inpatient floor setting, to continue to screen them and give alerts to the physicians, reminders for screening. We can also create referrals for patients who are hepatitis C positive while they are inpatient so that they have easier access to the hepatologist or the correct subspecialist who they need to see. And finally, I think that continuous education is important for resident physicians regarding the importance of hepatitis C screening. In the future, we are looking to, as I said before, create better physician training regarding the importance of hepatitis C screening, meaning in training sessions, more grand rounds, and education regarding the importance. I think we'll also be working with IT as well to implement these hard stops that will ensure that a patient who qualifies for hepatitis C screening will get screened while they are in an inpatient setting.